All right, guys, welcome back to the Hammer and Chisel Performance Podcast. I'm your host, John Heck. Okay, so the guy I have on today, we're going to take things over to the sports performance and physical therapy realm. The guy I have today, he is a doctor of physical therapy. He is a strength and conditioning coach. And to be honest, he is one of the most gifted, freakiest athletes I've ever met. I consider him a Tar Heel. He got his master's degree from UNC. So I think that meets the criteria of being a Tar Heel. Q Wiley, welcome to the show, man.
Thank you, man. Good to be here. Yeah, I mean, I played lacrosse at UNC, so there's some sport heritage too there, and I would consider myself a Tar Heel, so I appreciate the warm welcome.
Absolutely. And we met, in the motherland of Tar Heel Nation. And I'll give a quick backstory on that. So when I first met Q, I quote unquote discovered you. I saw you doing like a collaboration post with our friend Graham, the barefoot sprinter. And I'm watching this video and I'm like, who the hell is this dude? This dude is jacked. He's fast. And apparently he's here locally in Chapel Hill. So I had that in the back of my mind. And then one day I'm training at a local O2 Fitness in Durham on an off day. And I see this monster over in one of the platforms. I think you were doing a Jefferson deadlift or a Jefferson curl with crazy weight, crazy range of motion, and I'm like, that's that dude I saw with Graham on Instagram. So I approached you. We kind of struck up conversation, and the thing that I've always loved in strength and conditioning, and strongman and powerlifting, bodybuilding, is the opportunity to rub elbows with the freaks. And I saw you, and I'm like, okay, this dude's a freak. You're big, you're jacked at the time. You were like 240 something, got abs. And then, you and I got to know each other, learned you were a physical therapist, you had a local practice. And you and I talked, and I realized, okay, this guy's a pretty damn brilliant physical therapist, and he knows his shit when it comes to all aspects of training. And then I came to learn you were training for Team USA bobsled, and I'm watching you running a damn 4.5 40. You're doing these insane depth drop jumps and strong. And I tell people to this day, you're maybe the freakiest athlete I've ever met. Would you agree with that assessment?
No, no comment. All I would say is I have since the time I was very very young been very obsessed with like physical culture and I for whatever reason the cinematic carryover from Eddie the Eagle, if anyone's ever seen that movie, and there's a beginning of the movie where Eddie the Eagle is essentially like this kid performing all of these wild little physical feats in hopes that one day he would go to the Olympics, and everybody in his community and his parents think he's crazy. And it didn't matter what it was. It was throwing something, it was holding his breath underwater, it was just doing something that was challenging for the sake of it and just seeing how good you could get at it. Like that was me as a little kid. And so yeah, I think whatever developed during those early years of development just has never stopped, and I probably never will stop. So if that results in freaky athleticism, so be it. But I'm on the pursuit of ever-ending pursuit of betterment.
Yeah, man. And I know for a fact that it gains you additional respect and buy-in from your athletes. It did for me. So just to kind of round out that story, the more you and I got to know each other, we started training together, and I was dealing with some issues. I had, a severe nerve injury that I was dealing with. I had some bad FAI in my hip. And, the more you and I talked together, I was like, you know what, I need to go visit, I need to go work with you um, as a patient. So I went to your clinic, you worked with me, and I loved the training based approach that you had with my rehab. We weren't in there doing soft tissue work and cupping and dry needling. No, you had me get under a squat bar, and you were helping me, with my core bracing, adjusting my pelvic positioning so we could find proper positioning for me to squat where I wasn't getting that nagging FAI in my hip. You set up some milestones to start hitting, and training protocols to regain some function in my right leg. And I very much resonated with that training based approach you were taking, the therapy. And then long story short, you came over to UNC, introduced you to Coach Hess, who was at the time the head strength and conditioning coach there. You got to know all of us, and When I eventually transitioned out and went to the Houston Texans, and they were looking to fill a spot on the staff, I went to Hess and I was like, look, if you're not already considering this on your own, you need to hire Q. And I mean, I saw his eyes light up the second I said that, and then the rest is history. He ended up getting hired over at UNC. So I know I just rambled on a lot there. Just real quick, do you mind just giving a quick kind of bio resume overview of your career?
Yeah, absolutely. Yeah, so I played lacrosse, grew up playing a lot of lacrosse and football, but really probably more on the lacrosse side. I knew that I had probably more of a future in that. Before that, I loved basketball, and lacrosse just had a lot more of the characteristics of nature of basketball. And so played that in college. I went to Brigham Young University to start, became really interested in exercise science, and was reading textbooks and just figured I'd really like to be one of the guys writing these textbooks instead of one of the guys reading it. I wanted to be someone putting out into the world and know what they knew. And so I pursued a master's degree at UNC, and still had eligibility left over to play. And so I played lacrosse at UNC as well, while earning a master's in exercise physiology. Got really interested in strength and conditioning while I was there, and was beforehand, because I was always really obsessed with training and the idea of that and improving physical qualities. It just felt like something that we had a little bit more control over. And in something that's really chaotic like life and sport, where there's a lot of randomness happening and things you don't have control, training just felt like one of those things that was something that was a little bit more clean. And I liked that idea that it was something we could maybe know more about. And so helped with men's and women's basketball throughout my time at UNC as well on the strength and conditioning side. And the current head strength and conditioning coach for men's basketball, who was there when I was there, just said, if you want to continue in this field in the performance realm and strength and conditioning, and if you have the abilities and time to perhaps consider getting a medical degree of some kind. And so I applied for physical therapy school. I applied to one program, got into that one program because it was way late on the deadlines. I had missed all of them, but there was one that was still open. And so I just thought, what the hell, I'll give it a shot. And if I go, I go. And if not, I'll stay in strength and conditioning. I got in, did a doctor of physical therapy degree, and became ever more obsessed with training and therapy. I shared a desk with Greg Nuckols, if anybody is familiar with him, the Stronger by Science. I shared a desk with him in my master's degree program, and that also really kind of set the course of being integrated into the science communicator kind of realm of things. And he connected me with a lot of people in the training and rehab space that were great science communicators and very prolific evidence-based practice kind of people. And that's probably more than anything what really catapulted me into the direction that I ended up. And yeah, I think all through physical therapy school, I just continued to train for bobsled. And that was just a goal of mine that I really wanted to pursue for a number of reasons. And so all through my physical therapy program, I just trained like a savage and studied like a savage. And then when physical therapy school ended, I made it to a combine, then to pro day, or the rookie training camp in Lake Placid, New York. Made the USA national team and competed all over with them, and had a really great time. It's maybe something I'd consider possibly doing again in the future. But yeah, and ever since that time, I have continued to train that way, and train for speed and train for strength, and some conglomerate of all of it. And a little bit more of a generalist, but trying to maximize the physical qualities that I have for as long as I have them.
Right. And then obviously you spent, this most recent year working with UNC football, working for Brian Hess. And obviously there's a big transition going on over in that program, which the entire world is following very closely here. But let's go to, did you always, well, first of all, I thought you got great advice from, it was Jonas, correct?
Yeah.
The head basketball, and he's still there. Yeah, he gave you great advice because, you look at football and sports performance in today's day and age, and that kind of hybrid physical therapist, strength and conditioning coach has become a lot more prominent in the industry. When I was with the Houston Texans, we had an entire return to play department where there were 3 people on that staff. They were all DPTs, but they were functioning as strength coaches. They were on the field with whistles. They're in the weight room with guys more so than they were in the clinic. And, you know, back in the day, and not that long ago, you would just have your athletic training staff, you would have your strength coaches, there were separate entities. But now we're really seeing a lot more of that, like I said, that hybrid PT strength and conditioning coach, which I think, in my opinion, you're one of the best out there with that. Did you always kind of view therapy through that training lens? You know, I think when a lot of people think of physical therapy, they're thinking the clinic, they're thinking the passive modalities. They're not thinking about barbells. They're not thinking about training, right? Can you speak on that a little bit? Was that always the way you looked at it?
Yeah, it was for me, and sometimes I have a really difficult time relating to the other side of that fence where there is a lot more emphasis on the, gimmicks and tricks and passive modalities and doing this to somebody because I never felt like any of that worked for me as an athlete. I was always really a lot more interested on what I could do and how I could direct my efforts to make this problem of mine better. And every time that I got some kind of passive modality related stuff, it was like, okay, cool, you did this thing for a second, but this isn't hitting on the big picture of what needs to happen. And so I think even as an athlete, when I didn't have the knowledge that I had, it never really felt like those things were actually solving or addressing the bigger problem at large. And so it was easy for me to pick that up as a clinician throughout my professional career to look at more of the global perspective on this versus just making something feel good in the moment. And to quote, the recent quote that Tony Holler put out is a great track and field coach and a great coach in our industry, is that if rehab and training in your mind are not identical or nearly identical, then you probably don't understand either. And I would full-heartedly agree with that. I think that rehab and training, if and we're going to talk maybe about injury prevention, like, well, if we talk about injury prevention, that is training. I don't know why injury prevention is any different than training. We train to build resiliency in tissues to improve capacity of the human body to perform a task. And so there's no delineation in my mind between rehabilitation, between injury prevention, and between training. It's all the same thing. It's just a sliding scale of where on that spectrum, based on what things are going on, where you're at, but it's all the same.
Yeah, I couldn't agree more. Why is it? Why do you think it is that is not necessarily the mainstream view? Why is it then when people think of physical therapy, they're not, or injury prevention, they're thinking more of the pure clinical side of things as opposed to the training side? How did that come about? Why is that the mainstream view?
I think that in general, and it drives me nuts to this day, but I think a lot of people love the idea of complexity. They love the idea that something's got to be this like really like complex thing, and if I could just understand it more, and I could hit all the right angles and fascia and certain joints having this range and training in this different way that I've never considered, that's what I need. I need this sexy thing. And I think even when you were talking about folks in the NFL who are behaving more as strength and conditioning coaches, or they have that role, but they're DPTs. I think there's just something on paper, even to people from a face validity value, that like, oh wow, this seems like they have this a lot bigger knowledge than most people. They really must know all the little intricacies of moving this and moving that, just this one specific way. And the truth is that the more prolific and seasoned and best coaches take this complexity and they make it very simple. And simple often doesn't sell. Simple solutions, like when you came to me and we were just, all right, we're going to get under a bar. Like, it can't be that simple. Like, I've got to have something done to me to like fix this joint or move this thing a certain way or change this drastically. And I think there's just this gravitation of the general public that they want some fix, some big, really interesting thing that just sounds pseudoscientific that they've never thought of. And it's not that way. Because when you look at like complexity, because things are so complex, there's also there's often very simple solutions, because that means a lot of things can work, right? If there's so many inputs, and you think about what happens in the human body, I mean, literally trillions of neural interactions are happening every second in our body. And because we are so complex, that even supercomputers and AI have not touched what the human body can actually experience and process in real time. Because it's so complex, there's often very simple solutions that can create a wealth and a wave of influence throughout this system that's so complex. And I don't think people like that. Even the questions you posted on Instagram, some questions of what people wanted to hear out of this podcast. And I get this all the time, whether it's DMs, whether it's comments on Instagram posts. And we saw this happen in the questions as well, where people are like, what to do for this medial knee pain of this thing. And it's like they want some like really cool answer that like you just plug and play this thing for medial knee pain and this works every time. And there's even groups out there, like full groups of training cults that claim that they've found this like, answer to, if you have this, you just do this. And I talk about this in ways of like politics and religion, because we just see this in across humanity, that like we love this idea of certainty. We love this idea of things being checked off. And it feels very bad when we just don't have like some answer. We think, how are we this smart and know this much and have researched this much, and we just don't have like a protocol set answer for all of these questions. But like if somebody says they have medial knee pain, there's a host of other questions I have to ask and know about this individual, as far as how long it's gone on, when did it start, what are they doing about it, how is what they're doing working or not working, how do they like to train, like, like I've mentioned a fraction of the things that I'm going to pick up in a subjective, even just conversation with that individual, that it's not just as simple as like, I have this, do that. But people love the idea that like, you could do that. And I was the same. I mentioned in my quick little bio that when I was a student, I wanted to be the person writing the textbook. I wanted to know the one knowing all these answers, because it seemed like if I could just control training and just know enough about it, that I could master and control all of it, because there's no possible way that we couldn't finally get to this point where we know all of it. And there's even like philosophy where, they believe that if you just took the brain or the problems that we think about, even in like psych therapy, and you could just break them down into component parts, and then break those component parts into smaller component parts, to the point where you've gotten to the dumbest component part of that thing, the smallest little homunculi, that if you could just understand each one of those and then put them all back together, you would solve problems. But the truth is, when you put all these complex things back together, they don't behave the way that they did individually, separately. So it's way more complex than that. And there's so much nuance in this, that it isn't just, this one thing. And so when you talk about why is rehabilitation and training often separate, is because I think people want it to be this like really complex answer, when in reality, they don't understand that it's sometimes just a modification of training and adjustment of your expectations and how long something may take, or how quickly you're going to progress through something, or that you're trying to fit this square peg in a round hole of this one movement that you saw on Instagram. And for whatever reason, you keep doing it and it's not working. But they think, well, this guy said it would work this way and he's a rehab pro, so it must work this way. And it doesn't. And so, it can't, people don't want to think it can't be that simple. It can't be that simple just to adjust my training. And oftentimes it kind of is.
Yeah, I mean, it's how much of the time does the answer just come down to like a load management based approach? And a couple things, I pulled out of there are people's need for complexity and people's need for black and white answers. And I see the same thing from the training side. I see the same thing from the nutrition side. So many people out there are asking me, what's the best training split? What is the best program? Or, they want the complex training program. They see all the gurus posting the Dr. Joel Seedman stuff, the Bosu balls, the unique exercises. And I'm like, guys, like, let's not get away from the basics. And then also, there is no best way to do it. There may be a best way for you, or a good way to do it for you, but there's going to be multiple different effective approaches we could take. And then in the nutrition side of things, there's so much just black and white dogma, whether it's only eat meat, That is the answer. That is how our ancestors ate. That is how humans are meant to eat. Or don't ever eat red meat. Red meat's going to give you cancer. You need to eat a plant-based approach. What's the best diet? Don't eat carbs after 5 p.m. Just all of these black and whites. And people want that so badly. And I'm like, listen, guys, there's no best diet. There's no superfood. There's no devil food that we need to avoid. Like, let's look at the big picture context. Let's look at your lifestyle. Let's just find a multitude of foods that you digest well, that agree with you. Let's put them all together and into a calorie load that's going to allow you to lose or gain weight. And it's all just multiple pieces of one big puzzle. There's no right answer. And then there's nothing cutting edge about eating lean meat and complex carbs. And, there's nothing cutting edge with this stuff. But like you said, that doesn't sell. But the football world likes black and white. They like timelines. They like, when is this guy going to be back on the field? So what was that transition from the clinical setting to the football setting? What was that like for you? What were some of the pros and cons of both of those settings?
Yeah, and this isn't even unique just to football. I think football happens to have a lot of resource that they dump into this, and because they have a lot of resource and the power to do things, they think that all things that could be done should be done. And that happens even with the medical side in an organization like this, where you know, in the private sector, we may say, well, we should give this a course of conservative management before considering surgery. In the football world, it's like, well, we can't, chance this person taking a month or two of a conservative route only to have to get surgery anyways later. So we were just going to go straight to surgery right off the bat and, take it as it comes. And then on top of that, if you have all of these resources and all the things that potentially could be done, then your job is to just simply do all of the things, even if they're ineffective, a waste of time, and maybe build some really poor habits and mental schemas around how an athlete should think about their body. It's just like the nutrition side of things that you mentioned, or um, you could take this to any other industry, but it's like, if all of a sudden you have every single possible option at the disposal of your fingertips, you're just going to do it all. Regardless of whether it's the actual thing that should be done or is best, we're just going to do it all because we can. And I think sometimes it's not only wasteful, but it can be harmful, because you're probably often taking away from the things that would create 90% of the benefit, but you're spending only 10% of your time on it, because there's now 90% of the other things that you're now spending all the time on that create very little of the actual benefit being done. And so I would say, going into an organization, um, you have a lot of cooks in the kitchen, and you have a lot of things being done that maybe are not always in the athlete's best interest. You have a lot of things that you mentioned people looking at somebody like Joel Seedman, and he's just one, but any number of gurus or outside sources. I mean, I can't tell you how many guys would come up to me in like the lunchroom, like, "Hey, have you ever heard of this? You ever heard of this method, or have you ever heard of this thing?" And you're like, "Oh my gosh, here we go again." And it's some guru on Instagram making some wild, unsubstantiated, not evidence-based claims about how this is the only way and the best way, and you're just like, you're just the schmuck at the university that was assigned to work with football. You don't actually know what you mean. I got to go to all these outside sources that have all this, allotted fame and fortune to seek truth, because you're just the guy here. There's no way you could possibly know. Versus like when you work on the private side, people that come and seek you out, like yourself, like we developed a relationship. You saw value in maybe some of the things that I said or what I had. And then when you came to me, like you came and sought me out to work with me, that there's already some vested interest and buy-in there. And that our relationship now in that patient interaction or client interaction is a lot more valuable to you. And I can get a lot more in depth, and you're going to buy into that. And we can actually set these milestones and have this meaningful trajectory, versus like in the football world or sports world, you know, there's this always this drive of like, when this guy's going to be back, when's this guy going to be back, and they don't want to hear that, like, well, he's got to demonstrate X, Y, and Z before he can do that. And then they would get like, 70% of the way there, but it had been 4 weeks. They're like, oh, well, you're just not doing a good enough job. Then we need to make this move faster. And it's like, it's so funny that coaches who have a myriad of pain and problems and lack of physical abilities themselves, and are poorly managing their own health, or have struggled with pain and injury, and that probably oftentimes even they have stories about how something ended their career and whatever. They think that the athletes should behave wildly different that they're coaching, that like something that should take 6 weeks to potentially, 6 weeks, 6 to 8 weeks to rehabilitate properly, should take 3 or 4, because we just have all these things and we have the best and da 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 da. And then it's like frustrating when it doesn't happen. And it's like, well, you can't force human adaptation to take place way faster, especially when you look at kids that are probably not sleeping well. They're probably not hydrating well. They're probably drinking. They're probably like really overwhelmed with a lot of other social and school stress that they have to deal with day in and day out. Like, there's a lot of things going against them, despite how freaky they are and their age and how resilient they are. They also have a lot of other things going on in their life that may not be conducive for a really positive rehabilitation. And I think that is also something that's different in the football side, is that people have this like image of, oh man, like if I could just be these, Division I athletes, or these pro athletes getting all of this stuff and just being able to have all this time and resource to dedicate. And it's like, yeah, but they're still humans. They still bleed the same as you and I. And the body still is going to take time. And then not only that, but they have to return to a level that's a lot more violent than what most people are returning to. So when they have an issue, even though they're freaky and we do have all these resources, we're also asking a lot more of them. So now the timeline probably isn't all that different. And the way that this goes, and the epidemiology that, there's going to be injuries that probably last longer and struggle harder than maybe their counterparts do, that's just normal human behavior. But in the football world, it's seen as like, oh, well, something's going wrong. He must need surgery, or he must need some, over the top intervention. And it's like, no, this is normal human behavior. We see this happen across, the lifespan and skill span of a lot of different things, and we don't need to freak out about it. But then we go do these unnecessary surgeries that cost more time to rehabilitate from. You can't undo the surgery. We got guys going and getting the core muscle injury and groin repairs up in Philly, by some guy, and it's just like, okay, well, if we just managed these properly and actually ran a return to run protocol and tested things and appropriately introduced him back to play, we could probably avoid that. But because it's something that we have access to, we're just going to do it. And now, the athlete has in their mind like, oh boy, like I'm really messed up. I really needed surgery. No, you didn't. We just didn't have a chance to properly manage this, because the bureaucratic, political nature of a large organization doesn't always have the athlete's health in mind.
Yeah, I couldn't agree more with all of that stuff. I mean, there's quite a bit to unpack there. And I mean, just looking at the timeline part of things, and football's demand, like, oh, this injury, generically speaking, this should be a 12-week recovery. But to your point, well, okay, maybe that's a 12-week recovery for the average human who's returning to a desk job, but you're asking this athlete to go play high-level football and withstand violent forces at high velocities in a chaotic environment. Putting this arbitrary timeline, it'd be like a coach saying, all right, well, this athlete squats 405. I need you to get him squatting 500 in 8 weeks. And it's like, maybe there's some athletes who could make that sort of progress in that arbitrary timeline, but there are many of those who just aren't going to adapt to training in the same way as others. Everyone's going to adapt differently. And to your point, there's so many other factors that go into strength adaptations. Like, are you sleeping right? Are you eating right? Are you drinking? What are your stress levels? There are so many variables that you can't account for, that you can't control, just to get this perfectly packaged timeline, right? So what would the more optimal approach be when you're dealing with someone coming off of a surgery in
Yeah.
terms of timeline?
Well, and even to your point, what did it take for that individual in that example you gave to get to 405? Has he been through a lot of training periodization to get to that point? Because you're going to have diminishing returns the more time you depend on that. So like there's another aspect, like what's the training age and training history of this person, and I think that comes into play too with rehabilitation. What's the injury history and what's been done to that point to adequately prepare him to have high resilience to coming back. People that have, ridiculous amount of quad strength and quad girth going into an ACL surgery are going to have better outcomes on the tail end because they just had a higher starting point. And that's going to be different from person to person. And so, even if we were to use the femoral acetabular impingement, the FAI example, if you look in like a lot of surgeons' protocols and maybe even some research, 5 to 6 months is kind of this like return to play following hip arthroscopy. That you see that number thrown out a lot by surgeons. Most of the surgeons in this area as well will say like 6 months. And I've heard that from a number of people across the globe as well. But when you dig into a lot of the research on that, that's like just getting back to like normal, and normal is even a little bit skewed. We know that people that undergo hip arthroscopy will likely continue to have issues in their hip, that it won't always feel normal, that they're going to have ongoing pain in that area. It's just that they can do more with it, with that pain. But like they've now shifted what their new level of normal is. There's no going back. And that's okay. They could function higher, but like helping somebody see and set that expectation of like, this isn't gonna just totally eradicate and fix this issue. It's giving you a little bit of more lifespan in what we can do with it. But, even then it's like 6 months is not going to be full return. It's probably closer to 8 or 9, similar to more like that ACL. And even ACL may be closer to a year, depending on like, what that athlete has to do. So I think the way to think about this is less in terms of time, even though that sounds really nice, and we have a large swaths of data on about when people return, but the outcomes of that data, as far as at what level they return to. If they're a professional athlete, do they return to that same level of play, or do they now get relegated down to an amateur level? So they're still playing, let's say like in a soccer athlete, they're still playing soccer, but not at the same level. And so it could be the same Division I athlete. They're playing at a Power 5 type school. Well, we can say on paper, in a research paper, that this athlete returned to play, but now they may be going and playing in an FCS school. They're still playing Division I football, so it looks nice on paper, but they're not playing at the same level they were. And a lot of that is because we're I think we're trying to rush these things. We're trying to adhere to these timelines, and really rehabilitation should be a criteria based program. Every stage of the training should be criteria based as much as you can. Once you've been able to reach this criteria, now we can advance to the next stage. And I think oftentimes people, look at things like, well, we hit 4 weeks, so now we can start doing this. And it's like, well, maybe you can, but what did they demonstrate to prove to you that they can? And you kind of have to, I don't love I don't think it's a correct way of thinking about like earning your right to the barbell. I don't think you have to have some requisite abilities to now touch resistance training. I think that's totally bullshit. But I do think that in rehabilitation, there's probably some benchmarks that we want to be hitting before getting to some more aggressive things. Like a good example of this might be in ACL, which is usually one of the most like clean things that we have in the research because it's such a long progression and it's so tested. But like we want to see 80% of torque to body weight ratio in a knee extension test before we're doing plyometrics and return to run related stuff. Anything, prior to that, if they're not even close, not even getting to that 75% or higher of that torque to body weight ratio, you're jumping the gun. Even if they look good and they're telling you they feel good, you're doing that person a massive disservice by not continuing to train strength and get that quad back before doing some of these, more return to run things because it just has a higher yield. Now, that said, could you get away with it? Absolutely. People get away with it all the time. 100%. And this is not something that like is concrete, hard and stone, the same way that the timeline is not concrete, hard and stone, but there's mile markers and benchmarks along the way that give you some semblance of an idea of what is safe. And what's great about that is that your testing now becomes your training, right? Like if I test an athlete and I'm trying to get torque to body weight ratio on his quad and it's poor, well, awesome. We're going to do a lot of knee extensions and a lot of quad work. Like that, like now I have something objectively measurable that I'm trying to improve, and that can direct your training. It's the same reason why in performance, you have people taking force velocity profiles on acceleration and max velocity. It's just to direct where should we direct our training efforts a little bit more. Is this person really great on their first 1 or 2 or 3 steps, or are they better down the road? And, and are they great with resistance on and they're really strong in those qualities, or are they more of a turnover athlete and they just want to be frequent and try to use the air more? And that's just kind of guiding your training. And it's really no different in rehabilitation. We're just trying to get some semblance of an idea through criteria that they're proving or demonstrating that gives us an idea of I can tell a coach now, hey, I know that we said 6 weeks. Here's where he's at in this amount of time. It's been 4 weeks since this injury happened. He is currently demonstrating this quality. It took him 4 weeks to get here. Here's the remaining percent that we have to go to get him back to being ready to play. Based on how fast he's going now with this progression, we could probably expect somewhere in this ballpark that he'll be ready to go. But he will need to still demonstrate this quality before we feel comfortable allowing this athlete to play. And that is a lot more than just like, oh, he said he feels good, so awesome, put him back on rate, which happens tremendously more than people want to admit, but like so frequently in my experience in the college football realm, it's just like, oh, he said he felt good, so he's got to practice. He's got to practice, and it's like, okay, well, good luck with that.
Yeah, and then, how often is that kid probably also getting pressure, from his position coach? His position coach is asking, how are you feeling? How are you feeling? And he feels pressured to say, I'm feeling good. And then position coach is, coming to the strength coaches or the sports medicine, like, what's the deal? This guy says he's fine. We should be getting him out in practice. The coaches feel this pressure, like, I got to get my guys back on the field or I'm going to get fired. And then they're putting pressure on the support staff to rush their rehab. And it's just this whole circle jerk. And that's how rehabs get botched. I see it all the time. And you talked about kind of, the earning the right to touch the barbell. Well, let's say we're dealing with a kid who's, has a season ending lower body injury. Well, we kind of talked about this off the air. Great opportunity to bring up their upper body strength and train like a savage with all the other components that they can train. You know what I mean?
Yeah, absolutely. We don't want to get myopic, when you have an injury anywhere and to any degree of severity, and you may have time off of training, that's a great opportunity to use that time to maximize these other qualities that you may not get otherwise, and if somebody, let's say, is dealing with like a hamstring strain, right? There's going to be a period of time where their total amount of training volume is lower because they're not practicing. They're not hitting the same yardages and distances in a day. They're not training with the same intensity in the lower body that they maybe would prior to injury. So that being said, that gives me a pretty big window of other places that we can now place training stress on that we wouldn't get otherwise. That person, how do I keep that individual's cardiovascular health really, really good? Because now they're not running anymore. It's not about just rubbing and massaging and cupping and needling the hamstring to make it feel good so they can walk a little bit better in their gait pattern. It's no, we know that this musculotendinous junction in the hamstring, that's going to probably take what it's going to take, and we need to continue to expose them to levels of running that they're able to day by day, and we're going to feel that out. But how do we preserve everything else in lieu of this so that when they do return, everything else hasn't now also decreased, that they're now competing against athletes in their position that are, a couple of percentages above them in all these other categories, and now they're playing catch up. And I see that happen all too much. And there's a massive difference between feeling good and being prepared. And I think that's really where I hammer hard on training should be rehabilitation. I understand that you need things to feel good. I understand pain science and how sometimes doing some manual therapy and passive modalities can, decrease pain and then you might get a better training effect because now they're less apprehensive, whatever. I think that's fine. But if I can find all of that same stuff to happen, which I do again and again and again and again through graded exposure, that I can still numb pain. I can still decrease the amount of pain that the athlete feels from doing something simple like an isometric or, just exposing them to something that they had an expectation that it would hurt them and all of a sudden it doesn't hurt them. Boom. That's a huge violation of their previous expectation that I've just tapped into their brain that now they're less apprehensive. Now I'm getting a better training effect. So why do I have to do this table work when I can get all of the same potential contextual effects and non-specific effects from just movement and exercise and moving with them that actually does move the needle on a lot of the other bigger things that we think about when preserving tissue integrity and quality and movement pattern integration and things like that. Like I think that's probably where we want to spend the bulk of our time versus just making people feel good. I think probably the only argument that I've ever heard for passive modalities that maybe makes me feel a little bit more lenient towards that is just developing the relationship with the person, that getting them on the table and rubbing them for a second just allows you to talk to them how their day is, and what's going on in their life and how they feel about training and just letting them kind of vent to you and letting your and them's relationship, right, during that period of time that I care about you and I'm putting my hands on you and I am evaluating as we go. Sure. I think there's some interpersonal connection that can happen there, but when it comes to like what is actually creating the rehabilitative change and what's actually creating patterns and creating the resiliency in the tissue and getting you back to playing from a physical quality standpoint, it's certainly not any of this passive modality stuff. We have great research that really doesn't change histologically anything from a tissue perspective, and you can get all the non-contextual benefits from not doing that stuff too. So, I just have a really hard time in this industry where that stuff is put on such high regard and yet has such little outcome that it seems like we're putting a lot of our eggs in a basket that doesn't really have a lot of yield.
Yeah, you're gonna stir up a little bit of outrage among a lot of practitioners out there with the anti-passive therapy modality argument, which I agree with wholeheartedly. Real quick to touch on that point you made, though, that is a good point about maybe using it as an opportunity to develop that interpersonal relationship with the athlete. It's an opportunity to, hey, it's you and them, you're talking, you're building a little bit of that trust, that comfortability with the athlete, which I do think is important. To circle back to a point you made about working in the private sector, you're dealing with patients who come to you, right? They seek you out, they're paying you. There's already kind of that built-in buy-in and trust factor. I see the same thing now that I'm on the private side, doing private coaching. These are people who sought me out. They're people who are paying me. Whereas in the football setting, those are guys who have to be there. They don't necessarily want to be in there training. They just have to be. And that can change that kind of trust and buy-in dynamic. But anyway, you talked about one of your complaints with the football setting was we've got all these resources and we're potentially wasting 90% of our available time doing things that are probably not moving the needle. Are you kind of referencing those passive modalities, whether it's the cryotherapy, the cupping, the dry needling, the foam rolling? Is that what you were kind of alluding to earlier with some of the time wasting?
Yeah, in part, some of the passive modality related stuff, I think we do spend a lot of time or we place a lot of gravity on that like, oh, I need to go and get that because that's what's going to make me better. And it does pull away from some of the time. But I would even say that a lot of the time on the rehabilitation side of things, the training stimulus is also so poor. It's so low. It's so minimal threshold. I mean, I can't even tell you the number of times that I've heard athletes come back from like a training room or something and say that we worked on my pelvic positioning and my diaphragmatic breathing, and I blew into this balloon and did these like things, and I'm like thinking to myself like that's such a ridiculous waste of time and energy and resource that doesn't move the needle very much at all, and doing these things that like they can just breeze through and they don't even know why the heck they're doing it. And, you know, I, I understand that, you're trying to build a relationship and build value in a situation, but man, I guess I just feel that, why can't you do that with effective communication and effective questions and questioning the epistemology of the athlete and why they feel they need what they're asking for, and understanding why it is that we do the things that we do. Like a strength and conditioning coach that never puts his hands on an athlete can have a very long lasting, powerful relationship, as you've experienced with athletes, where they really value your input and time, and you didn't have to do all that stuff. And so I think there's a lot of ways to do that. And yeah, I very well may ruffle some feathers, but I think even somebody who's a proponent of manual therapy and has done probably some of the most research in the manual therapy world, Chad Cook, who's at Duke, um, published an article in 2024 with a number of other clinicians, even people like Adam Meekins, who is a clinician who's very on the other side of not wanting to do manual therapy, but they published an article talking about like how how to employ manual therapy for the modern therapist, and where are we at currently with research and how should this be done. And much of what they talk about, even people who use a lot of manual therapy talk about it should be kind of used sparingly, maybe in the beginning stages, but we should try to move away from it as soon as we can. And then also showing the person how they can do manual therapy related stuff for themselves. I think it's a hilarious idea, but like people love the idea of like getting a massage, right? Like the idea of something rubbing them, and it's like, what's funny about that is like, why can't you just rub your own leg? Why is it that someone else rubbing your leg creates this effect, but rubbing your own leg doesn't? But yet we use narratives about changing the blood flow and the fascia and releasing tissues and changing da 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 da. Well, then why doesn't it work when you just do it to yourself? Because none of those things actually happen. Like the narratives that are often placed behind the use and the rationale for using some of these therapies, it's funny how often they break down and there's no substance to them. And so I think that, if we can show athletes how to be efficient and self efficacious for themselves and doing these things and performing these things to get relief when they need it, that's empowering them and placing them as agents to be accountable, that they can now handle and take care of their health, not just in this exact one moment, but forever after. And I think that's a lot of what we're trying to do. If you zoomed out even more for the philosophy of like why we even have sport in the first place, why do we even train and do these things? Well, not only just for physical health, and not only just to like win, but like we have sport to like make us better people, and it's fun to engage in these things. We like to compete. We like the idea of engaging socially in something that there's a challenge related to it. People generally like to compete. They generally kind of like to work. We just want to feel that that work or that competition is valuable and that there's some social or positive interaction that comes from it. So like at the end of the day, we're doing all of this to like kind of better ourselves in a lot of ways. And to me, it just doesn't make sense that like we're treating these people as victims and we become the operator, that you need me to do something to you to fix you and your problem. And you're taking all of the autonomy and power and health literacy out of their hands and just doing something to them, when in the end, or I should say at the very beginning of all this, why did we even pursue any of this stuff in the first place? And we just slowly drift further and further away from that as a society. And that's why I think I give a lot of pushback on this type of area.
Yeah, and just to unpack a couple of things in there. First of all, I think you made a great point with just some of the time wasting stuff, just the low level stimuli you'll see a lot in the training room. Like I remember as an athlete, like if I was, dealing with a knee injury, how often was I in the training room just doing some half-ass TKEs, or, someone's got a shoulder, they're in there doing, they're talking to a buddy while doing some half-ass light band rotator cuff work. And they're sitting there checking a box in the training room. They're not actually dealing with anything that's going to push the needle in terms of tissue adaptation, no real load, versus, maybe a legitimate isometric progression or legitimate loading in the weight room. You're right. I mean, how much time is wasted in the training room just with this low level stimulus stuff. But then getting back to some of the passive therapies, I mean, I spent time in a program, an NFL program, where we allocated legitimately the majority of our training time was allocated to foam rolling. Whether we had the players on a foam roller and we were on a stopwatch guiding them through every single muscle group, no matter what no matter what we were doing that day, or we would have guys on the massage table wasting half of our staff with a tiger tail roller, rolling guys out. I mean, it taking away from half an hour of our 2-hour training window. And you know, even the players hardly believed in it themselves. And, a few of them, they subjectively, they feel better. And, just my own personal story with foam rolling, I'm completely, I think it's bullshit. I used to feel like I had to foam roll. I was exposed to someone early in my training career who put me on foam rolling, kind of made me believe, oh, this is, this is key. It's going to prep your tissue. It's going to prevent injuries, blah, blah, blah. So I got into a habit of, before every training session, doing a 20-minute foam roll session. And it got to a point where it became such a crutch that I felt like I couldn't train if I didn't foam roll. And then I went to the Carolina Panthers. I was working there. And one of the physical therapists came up to me and was like, why are you spending so much time foam rolling? I was like, because it prevent injury. And he was like, you need to stop. You're going to get addicted to this. And he was like, just humor me. Tomorrow when you come in and train, just don't foam roll. And I was like, okay. So I come in tentatively and I don't foam roll. I go through a dynamic warm up and I get under the bar and I'm waiting for my quads to explode. And sure enough, they didn't. I felt great. I felt no different than I did had I foam rolled. And then it flipped that switch in my head, kind of like you touched on earlier. It violated all my preconceived notions. I realized in that instant, I don't need the foam roller. And I have not touched a foam roller now in 8 years since that time. And now I'm saving 20 minutes. I'm saving space in my gym bag, and nothing has changed. And, we see how many programs do we see just wasting time doing all this bullshit passive therapy that's not doing anything. And, I think it's almost like there's this pressure to like, oh, I need to provide value. And it's the optics of, oh, we're doing soft tissue work. We're doing something, we're preventing injury, but it's just, it's just been completely debunked. And I would love to see it done away with almost entirely.
Yeah, I'm with you. There's a couple of things that are like to people listening, like, is foam rolling just this inherently bad thing? Well, no, it's not. That's not what we're saying. And it's like you just have to find the minimal effective dose. Like if somebody feels that just rolling around on a foam roller for a second just sort of like feels kind of good and wakes them up a little bit, great. Like I'm not gonna push back against that. And you have these like test retest type studies of all kinds of different modalities and things like that, where they'll do something, they'll test them cold, and not really give them a whole lot of cues or a lot of idea of what's going on, and then they do this like guru fancy movement or release or something, and then give them all these cues and help them know what's going on. And now they've had experience with the test, and then they go back and like, yeah, see how much better that is? Look what I just did, and it's like, no, you didn't. You didn't do anything. They could have done that before. You just didn't give them all of the contextual stuff going on before. And if you had and give them a couple of warm-ups and practice at it, they probably would have gotten the same place, because we know that stuff doesn't actually change tissue. And I think you just mentioned something really powerful that I have a significant issue with, and I think most people in the physical therapy and rehabilitation space is that somebody made you believe that you needed that thing in order to perform, that it was something that you became reliant on. And I think, that's where I have a really hard time with manual therapy, because it's very difficult to, even if you don't say those things, and even if you say something opposite, if you say you don't need this, it's really hard to take it back, right? Once they do it, and there's like some kind of subjective feeling, even if it's transient and only very momentarily, and it just kind of has this high face value, face validity, where it's like, oh man, this thing that hurt on my leg, he pushed on that thing, so it must help that thing that he's pushing on. Or I saw this needle go in through my skin into the tissue, it must be poking or prodding or doing something. So there's a very high like placebo effect and this face validity that's there that you can't take away. No matter how many times I tell somebody that this dry needle does not change a quote unquote trigger point, it does not change the fascicle of the muscle, doesn't change the tissue whatsoever. It's hard to take away some like very weird contextual things going on where they now become reliant on it. And I even go to, speaking of public gym like O2, you know, I went to the public gym the other day and now they have a physical therapy clinic in there and they were like literally advertising on a whiteboard in the front, like free dry needling, come ask us and consult us with, you know, and it's like, of all the things to offer the general public that are overweight, who don't manage training well, who don't even really know what they're doing in the gym or how to train or what their goals are, how to manage these things. And then you're just going to blanket offer this like band-aid fix all that's just going to like temporarily fix them. And you're saying that this is going to get them in the door and add value. Like you should be adding value by offering education, add value by offering uh sessions of like, hey, let's do a program evaluation. Like, what are you doing? What are your goals? Like, those are the things that are going to hammer way more long-term health outcomes than just sticking a fucking dry needle in someone for a second. Like, that's absurd that that's the level that our healthcare system thinks that we need to come in with people because of the sociocultural like level of status that we've reached. And I think we've devalued the entire ability of rehabilitation to make meaningful change. And that's why, again, I push so hard that like training and rehab should be more of the same, because there's a lot more of these long-term health outcomes that are going to happen by having these hard conversations, by doing an evaluation in that form and helping people manage their training and their goals and all of that stuff, and overcoming fear of movement versus just, let me just do this thing to you in the moment.
Yeah, and it's almost like some of these coaches and practitioners want to get people reliant on some of these passive modalities because then they have something to provide value. Like, oh, this athlete needs me. This athlete needs the dry needling. This athlete needs the foam rolling. That's something I know how to do and I can provide them. Now they need me. You know, I felt like in, you know, the program I was referencing where we did so much of the foam rolling and the soft tissue work, it was like almost indoctrinating the players with the belief that they need that, because then it allows that coach to provide value because that's the thing he knows how to do, and now they need that. You know, he had people believing that if he manually released their psoas, that fixed all their issues. And again, he was just providing this guru value. I just poke and prod around their psoas on the table, and then I do this little test retest, like, oh, you had this little asymmetry. One leg was longer than the other. Your hips were shifted. Now I rub around your psoas. Look, your legs are even now. We just prevented a catastrophic injury that was surely going to happen had I not done this. It's
Yeah, and then completely disregarding the like dozens and dozens of clinical trials that show that even experienced clinicians are completely awful at measuring movement of the pelvis and leg length discrepancy, and that they're wildly different on the same individual. Yeah, you know, just so invalid in that category of thing.
Well, let me ask you this, and this will kind of segue into a little bit of another topic. You know, we talked about earlier some of these arbitrary kind of pressured timelines with athletes that, you know, oftentimes you cannot meet that timeline uh, any sort of ideal manner and it's rushed. Do you see some of the opposite where, you know, let's say someone comes off of a surgery and then the doctor says, oh, they cannot lift more than 10 pounds for 6 weeks, and then it's bullshit. Like, you should be getting them back into some sort of loading before that. You know, I had a gallbladder removal surgery recently, and the doctor told me, you know, you can't lift more than 30 pounds for 6 weeks. I mean, 3 weeks later, I was squatting 500. And I mean, I'm not saying, now, was that me being a dumbass? Probably on some level, but there was absolutely a happy medium where, like, okay, I don't need 6 weeks before I can, you know, pick a textbook up off the ground. Like, I can get back to some loading earlier than that. Do you see some of that as well?
Oh yeah, yeah. I'd say, like, even in the world that we've been talking a little bit about femoral acetabular impingement, and in that world of hip arthroscopy and post surgery protocols, I mean, the variation between surgeons of doing the exact same surgery is crazy. I mean, like, Some it's 4 weeks, non-weight bearing, some it's, crutches up to a certain point, and then you can start weight bearing. Like, the variation of these is so wild, and so people have to understand that a lot of the reasons of these protocols, they exist just because somebody somewhere at some point did a study on like one particular population, that found like at a certain point we increase stress in this tissue by X amount. And so it just gets blanketly applied across the board for forever, forever years to come until that thing gets questioned. Now that's not to question research. I think some people in this field often say like, oh, practice is way ahead of the research, and we don't need research. My experience is telling me everything. And it's like, great. So you're saying your very biased opinion is better than you know, uh, swaths of data from, epidemiological and other type of study. Like, that's not true. And so I do think that these protocols do exist for a reason. It's just that there are variation that exist in the data. And so when you're looking at things like even hernia stuff, you could talk about hernias, and after a hernia repair, there's like all kinds of recommendations of how much weight you can lift and when, that are just kind of these, like, I don't know, we think this is probably the best recommendation. And we do hernia repairs on all kinds of different people with varying degrees of tissue integrity that we had to, fix. That we're just going to put this out because it seems safe and we're trying to cover our ass. And we don't want people to, do something that now screws up the surgery. And we said it was okay, and now we got to do the surgery again for free. Like, so we're just doing, basically covering our ass kind of work, when you do that. But yeah, I think that there's a lot of times where athletes are significantly underloaded for a much longer period of time than they need to be, and we could probably get to some work a lot sooner. And I think that some surgeries are a little different, where you can't always rely on just symptoms, because there may be nerve blocks, there may be cutting of some nerves where the feeling has changed, where they're just not even going to be able to pick up on changes in homeostasis of that joint or that tissue for a little while, and that may take back, some time to get back, and that's why we're sometimes overly cautious. But that's not in all cases, and yet the blanket recommendations in all cases sometimes gets a little too extreme. So again, we're it's criteria based, right? And can you demonstrate this? And if so, what does that mean? I think when it comes to the surgeon's protocols, we're in kind of a standstill where, yeah, we're probably going to just have to adhere to the bulk of what they say, even if we feel it's totally bullshit and they could do a lot more. Because they're just trying to save their ass. And what happens if something goes wrong? Well, now you got to go back and get surgery. But yeah, I think we're far too cautious on that. It's just that I don't think the solution is at a place right now where it's extremely movable. I do think that, there's probably a lot more creative ways to get around certain things where you're not loading tissues. Like, let's say somebody, and this happened 2 or 3 times at my time at UNC, where people had hip surgery or some kind of a core muscle injury related surgery or injection. And the recommendation was that they could not do heavy lifting like a bench press, right? Well, I understand that if your feet are flat on the ground and you're laying back in a bench, you're kind of getting this like stretch on the anterior chain and potentially bracing and loading a core muscle that was repaired, and that's a problem. But why could I not put this individual on the ground with his knees flexed at 40, his hips flexed at 45-degree angles, and he's doing like a floor press with way heavier weight than what's on their protocol, with him just staying really relaxed in his trunk and core during the whole time. And now I'm getting a better training effect on the upper body. But the unfortunate part is that, like, surgeons, for the most part, they're good people, they're smart, but they don't know training. They don't know how to exercise in the gym. They don't know the ways that a strength coach may do things. And to their credit, like, there's a lot of bad physical therapists and bad strength coaches out there that are just going to do really dumb shit. So, like, we're all just kind of trying to work together on something that's kind of complex and complicated. And there's maybe a higher risk, and you don't know what the other person's going to do, and you're not really familiar with like their side of things, which is where like some of the relationship between surgeon and practitioner is maybe a little bit better sometimes, even in the private sector, or it can be, because they know exactly what you're going to do. And I think sometimes in the university setting, both parties get so busy that they don't communicate and they stay very siloed. But if they could communicate a lot more, I think maybe there'd be better understanding reached and some movement on those protocols for those athletes with that individual coach. And we do see that happen. It just takes time. I don't know if there's going to be a blanket answer to that one, though.
Right. Well, what I wanted to kind of segue with that is, maybe getting out of just the sports performance realm, getting a little bit more into, something that applies to Gen Pop. Just talking on, doctors maybe giving these overly conservative kind of cover your ass prescriptions and approaches post injury, post surgery, whatever. Do you see a lot of fear mongering out there as it pertains to rehab, as it pertains to pain? For example, like you and I have talked in the past about back pain, and someone like Stuart McGill, who I think he's done a lot of great things, put out a lot of great information. But at the same time, there are people who kind of buy into the Stuart McGill ideology, who they experience back pain or a back injury, and then they're terrified to move if they're not perfectly neutral spine, core, braced, moving, robot, perfect. Can you speak on that a little bit? So just some of the fear mongering and fear of moving and loading.
Yeah. Yeah, to that point, there are folks like Stu McGill that I do think did a lot of good in providing a lot of interest and research interest. Even people that were skeptical and wanted to push back against some of the things you were saying. I think that did stimulate a lot of thinking and a lot of ongoing research, which is good. But I would say that a lot of the um, ideas that are continue to be proliferated by himself now, as well as from some of his earlier works, have probably done a lot more harm than good at this point. For that reason, is that it becomes this fear mongering thing, and if you don't do this, you're going to get hurt, and we don't really have, like, the data doesn't support that. It doesn't back up those claims. And again, like trying to take something like we talked about earlier, like trying to take something and break it into its smallest component parts and see how it works in the smallest component part, and then put it all back together again and make wild claims about what it does now in a system that's complex. It doesn't always work out so well. And I think some of the earlier research on some of that probably was a extreme version of that, of trying to break something down to a very small component part and then just applying it in painting in broad strokes to the whole thing that's going on, and disregarding a lot of other important pieces of information there. And I think the fear mongering, you see this happen, like a lot of people with like the functional movement pattern training and fascial training nonsense that's out there, where why are we lifting with heavy implements, and you shouldn't lift heavy weights, like you know um that's bad. And it's like, well, there's a lot of data that suggests how important that stuff is for rehab specifically. Not even just performance, but even people that are actually injured, dealing with histological and morphological changes in tissue, that these resistance training things with heavier loads and these heavier implements and these very like pre-planned related movements actually are extremely valuable and useful, and have a use. But I think that there's so much fear mongering because, again, just like with the passive modality stuff, it makes people subservient to your expertise. It makes them feel that you have some added value, something that they don't have. It places you hierarchically in a place where you are now the student and I am the teacher. And you need me to operate on you, whether it's operating in the knowledge that I have and telling you what to do and when to do it and what not to do, or if it's me doing this thing to you. I've just placed myself in a higher social status to you, and that you have to either pay me or come see me or regard me, to revere me in this way. And I think that that's really unfortunate. And a lot of the times people will say, oh, well, I don't deadlift because, I hurt my back deadlifting one time. But there's plenty of people that have hurt their back playing pickleball or hurt their back running. I mean, I made a funny post a little while back about, like, if you hurt your back having sex, are you just going to stop having sex, for the rest of your life? Because that's now something that you attributed, like, I hurt my back doing it, and now I'm never going to do that again because I hurt my back in it. And like, probably not, and so we can't just say that these things are, inextricably tied to one another. There's probably so many other factors going on of why that happened. And I think that the barriers of entry to movement that people place in the form of fear-mongering is doing society at large a massive disservice when you put so much out on social media that this is how you need to move, this is how you're supposed to exercise, and if you don't do it this way, it's risky. Well, in a society and a population that's struggling to even meet minimal physical activity guidelines in the westernized culture, adding more barriers and adding more complexity or barriers of entry and this need to do things right. And if you don't do it right, it could be dangerous. Like you're just adding more barriers to the thing that we need people to do more of. And then you can find just as many, if not even more examples of people doing absolutely bonkers, wild stuff, whether that be in athletics with the forces and the collisions and the movements that they get into as they do in weight training. And what's crazy about this whole thing is that, we have these fear mongering folks out there, and yet we have great studies on resistance training demonstrating the injury rate per hour of exposure to things like Olympic weightlifting, even level Olympic weightlifting compared to like recreational biking. You're saying that your kid outside just riding his bike with his friends is at a higher risk than doing like, training for the Olympics in Olympic weightlifting at a very high level every day. He's doing that. And you're saying that riding a bike with his friends is more injurious potentially, but yet we're going to blame this thing over here for injury. And it's crazy. It's just like such a dismissive way of throwing out this idea that people can't adapt. Again, going back to we want to think of this human as like everything else in our environment, cars and computers and architecture, that like, oh, we just fix this thing and it makes it better. And we just research it enough and it makes it better. But if we just control all these pieces and parts, we make it better. But all of these things that are in our environment, they don't adapt. There's no movement. There's no growth. There's no ability to change, to morph and move. And all of these systems, like a car doesn't have this, crazy complex brain that is ever changing and that the body is ever flowing. When I turn my car off and it's sitting outside in the garage or in the lot, it's not doing anything other than just getting worse, eroding away slowly. The paint's slowly getting less of its natural color because the sun's hitting on it, the weather's hitting it. But bodies don't work like that. So why is it that we want our world and the way that our environment to operate, and think the same way about our bodies? It doesn't, and we need to get away from that. And fear mongering around movement is just insane, especially with the problems that we have at large and the movements that are going to happen. Like, prepare yourself. It's all about doses. The dose makes the poison, man.
Yeah, I couldn't agree more. I mean, I could listen to you talking this stuff all day, and we could go down so many of these rabbit holes, and just they could all be their own podcast in and of themselves. I feel like I should get CEUs just from listening to you talk. So should my audience. Well, listen, I put up a post having people send in some questions on Instagram. I don't want to keep you too much longer, so we don't need to unpack all of these at depth, but we can kind of rapid fire if some of these, and some of these are going to be like, it's a big question that assumes a black and white answer, and there, like we have touched on, there is no black and white answer. So some of these questions, folks, the answer may be it depends type of thing, but I've got them pulled up here. We'll go through some of the good ones. Okay, rehab for interior medial knee pain. Only feel it when doing piriformis stretch and Nordics. And actually, this is something that I remember you specifically intervened with me. I was doing Nordics. I was having interior knee pain when I did it. And what you did was you cued me kind of squeezing my knees together in adduction, or even bringing my knees completely together during the Nordic. And that worked for me.
Yeah. A lot of times if you're experiencing that medial knee pain, and sometimes it's just medial, and sometimes it's also a little bit posterior in the back, a Nordic hamstring curl, because it's a predominant knee flexion based exercise, you're going to get more medial hamstring group engagement, because the two medial hamstrings, semitendinosus and membranosus, don't have attachments as much like down the femur as something like the biceps femoris, which is your lateral hamstring group that has a short head that attaches just on the femur and not the pelvis. So it acts as a little bit more of a knee flexor, but it's bigger on the outer portion in helping with external rotation, where it helps more with like a hip extension related work. And so when you're talking about just isolated knee flexion on that inside, we know from EMG as well as forced strain gauge research that the medial hamstring group gets a little bit more active in that. It can, in some people, it attaches partially to like the medial horn of the meniscus. That's not in all people though. That's just on like some. We have variations in attachment sites with that, but yeah, if you're experiencing that, it's probably because you're doing just a really intense knee flexion dominant exercise. Some options you have is to externally rotate your tibias, where you're just toeing out slightly when you do your Nordics versus even straight up. Or like, John, you just said, you can try to squeeze your legs together, whether you put like a yoga block between your knees if you need a little extra space or just something to cue you there, or between your feet and squeezing hard. What that does is it just, by engaging the adductors, you're also going to get a little bit more external rotation sometimes in the femur and a little bit more co-contraction of that lateral hamstring group, taking off a little bit of pressure on the medial side of things. And that just tends to work. If you're getting pressure with the piriformis stretch and you're getting that medial knee pain, sometimes that can be just joint line tenderness, whether that's from a true meniscus related thing, or if you're an older individual experiencing medial joint line tenderness, sometimes that can be the beginning stages of like our arthritis type things that you can feel. There's ways around that, but I'm assuming it's probably more a younger person asking if they're doing Nordics. So we'll go with what's already been talked about to this point.
Understood. Okay. Next question. This is a good one. Helping athletes overcome the mental factors associated with injury and the rehab process. Now, this is one I'm sure we could do a whole podcast on, but maybe we give just some brief advice on this, because this is an issue.
Yeah, yeah. We know and we've talked about this a lot, but FAI, the comorbidities skyrocket when we've studied this with femoral acetabular impingement in people that get hip arthroscopy surgery, that feelings of depression, anxiety, sleep disturbances, all kinds of other lifestyle factors really become an issue during that time period. And mental health is massively problematic, because usually, especially for athletes, your identity is so tied into your physical ability that when physical ability is now challenged, it's challenging a lot of what you have attributed of what and who you are. Anytime you're faced with that kind of a thing, it's going to be really challenging. And so having, either whether that's a mental health provider talk to you during this time period to focus on all the other aspects of who you are can be helpful. Putting things in perspective, I should say. And then also just setting like these meaningful, realistic goals and benchmarks kind of gives this carrot dangled in the distance that every time you reach it, you get this like immediacy effect of like success, that I'm making progress. I'm doing something in the right direction. It's really tough in rehab to help people see that this ideal version of themselves that's somewhere way off in the distance, that feels forever away, they want to chase that. Like, I want to be back on the field, back playing in games, da 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 da. And it's really difficult to get them to think in really small bite-sized portions, where it's like, well, okay, that's this ideal version off in the distance, but what's ideal version of you tomorrow?
Right.
What's ideal version in a week from now, in 2 weeks from now? And can we focus our attention on that? And that can significantly help that mental health side of things. But yeah, that's why doing this one magic exercise and doing this thing, or doing this thing to you with my thumbs, or a thing that misses so much of what happens in rehabilitation. The mental side of things and the expectations and the way that you think about this, the mindset, the way that you're challenging all of these other frameworks of thinking, even so much that we're talking about metaphysics of who I am as an individual, like that's deep. And if you're just doing something that you're saying, oh, you just do this exercise and it fixes it, or yeah, you just got to come see me to, get that adhesion out. Like, what? You just missed a massive portion of what happens in the human experience when dealing with rehabilitation and injury.
Yeah. And I know for me personally, kind of like you said, setting those short-term goals, that's huge for me, as opposed to you're just focused on that one long-term, back to 100%, versus you set those okay, here's a goal to hit maybe next month. Here's a goal to hit next week. And it feels like you're winning, you're progressing, you're chasing something that's attainable along the way. You're getting that positive reward feedback over the course of the rehab. I think that's big for a lot of athletes and the competitive nature of them. Okay. Best resources and or continuing education for PT.
Yeah. I think what might be helpful for that is if I just provided a list and maybe we could put that in like show notes or something like that of the podcast. There's a lot of good resources, both free and paid for, and mentorships. Like there's so many people in this space who actively are trying to change it and are science communicators as active rehab clinicians that want to see the field do better. And so we can put together a list of that people can check out in the show notes and check out all of those resources. So
And like I said, I mean, these people should get CEUs just for listening to you talk on this podcast right now. But yeah, I'll include those in I'll include those in the description of this. Q, I'll grab those from you, and when this gets posted, I'll have it in the description. Okay, let's see. Starting tips for rehabbing turf toe / loss of big toe abduction.
Mhm. Yeah, so turf toe really common in athletes, and it doesn't even always happen the way that the mechanism of injury typically is thought of, where the cleat's facing down or the foot's facing down, and an athlete lands on the back of the heel and presses the toe into the ground. It can just happen as a result of a lot of acceleration work, change of direction work, just a lot of on your feet stuff, and there could be these things that develop like in sesamoid bones and the flexor hallucis longus tendon, the same way that a tendinopathy can develop really anywhere. So it doesn't necessarily have to be a traumatic injury. But I would say, again, going back to first and foremost, when you're dealing with this, certain things are going to be really painful early on. And those things you're probably not going to be able to lean into as hard, and you're going to have to let go of some of your attachment to that. Where, man, I can't like sprint. I can't put on the accelerators like I want to right now because it kills every time I do. Okay, great. Like I understand that. So what are ways that we can improve some of the qualities that are involved with sprinting and some of the capacity work that feels like that, even if it's early on, just having to get on like a bike and do bike sprints. Okay, that's better than just not doing anything. So it's maximizing all the qualities around the foot and ankle that aren't painful. That's first and foremost. What do we have at our disposal that doesn't bother you? Okay, those have to go in the program, right? Like that's first and foremost. Now to get specific to the toe, um, you know, that's if it's capsular, like if you're dealing with like actual capsule irritation of the MTP joint itself, you're probably not going to do any magic exercise or drill that's going to get that back really fast. I'll have some people just like take their heel and step on the nail or the distal portion of the big toe, and then just so that there's pressure to the toe where it's pinning it to the ground, and then just try to pick their heel up with a passive toe and just kind of rock into that, and that kind of feels good. You can almost even pull your foot away from the heel that's pinning that toe down, so you're getting some active traction
on it.
Yeah, that traction, that distraction of the joint, and then go through some motion where you're doing some self modes. And if you came and again, like if you were to do some hands-on stuff, with somebody, sure, they can do some roll and glide type techniques to maybe kind of temporarily improve that motion and make it feel a little bit good. But it's one of those things that just as you grade your exposure back into things that don't bother it, it likely will get better on its own with time. And you're just trying to maximize the qualities all around the foot and the ankle and leg and the person as a whole while waiting for that thing to heal. There's also like management strategies like orthoses and little foot plates that you can put in to reduce big toe extension in the cleat or in the shoe for a period of time that can be helpful. But yeah, it's not going to feel super great. And if you're experiencing a lot of point tenderness underneath the ball of the foot versus just in tension testing, you may want to check out getting imaging because you may have some sesamoid bone fracture type things, and there could be potential for some different management strategy in that case if it's not being managed well and it's not getting any better.
Got it. All right. Next question, and I can kind of take the lead on this one, and you can piggyback or provide your insight as well. How to keep athletes ready to perform and maintain off-season gains in season. Okay, so obviously, we build up strength and size and all these different qualities in the off season. We get into in season mode, and now we've got sports practice, we've got games, we've got all that. So we're allocating a lot more volume to the sport itself, and obviously that now takes priority over the weight room. But in the weight room, we can still absolutely maintain, if not gain ability. Through Joe Ken, my mentor in strength and conditioning, he had a phrase I like: small doses of excellence. So we're probably going to be spending less time in the weight room, doing less overall volume, shorter sessions, but still getting a tremendously high quality of work within the work that we are doing. So we had an approach at UNC, and I'm assuming it was probably a similar model to when you were there last year, and where we would alternate between 2 weeks of strength work followed by 2 weeks of dynamic effort work, 2 weeks of strength work, 2 weeks of dynamic effort work. Where on the strength weeks, we were working up to, a heavy triple or a heavy double in maybe the 85% or so range on our main lifts, retaining a lot of those strength qualities. But then we would rotate away to the dynamic effort work. So now we're working on more the rate of force development, the power output side of things, and that kind of undulation between the heavy and the light work. It allowed us to stay fresh, stay recovered. We weren't, overtraining with the heavy stuff, but we're still touching on it. And then we're still able to touch on those explosive rate of force development qualities. And over the course of the season, we would have a progression of accommodating resistance where we would start with maybe just bar weight week 1. And then the next time we rotated back to strength work, we would have chain weight on the bar, a little less bar weight. We'd replace it with chain weight. So we're still getting high overall loading. We're still getting a great neural stimulus, but as they get into the bottom of a squat, for example, pressure is taken off as the chains deload. It becomes easier on the tissue, easier on the joints as they start experiencing wear and tear over the course of the season. And as the season goes on, we keep introducing more chain weight and less bar weight. But again, they're still touching on heavy weights. They're still touching on explosive weights, just at lower volumes. And like I said, small doses of excellence, getting a high quality of work in a short period of time.
Yeah, I love that quote. I think there's even a good amount of research data to back up the idea that you really don't need an awful lot of volume to drive the adaptations you're interested in when intensity is fairly high. And so you could probably do, so yes, you're right. At UNC, we kind of had the same thing of a bi-weekly undulating periodization between strength and dynamic effort. I think you could even make that a weekly undulating. You could even go daily undulating with more of a high-low type model, where even if you wanted to get wildly complicated, more so than what we usually do in the college sector, you could probably have 20 or 30-minute, lifts is all, but maybe more frequently throughout the week, where you're undulating between strength and power in very small doses throughout the week and still yield a very high benefit. I don't think it needs to be rocket science. You can still find ways to lift heavy to maintain strength adaptations in low volumes. You can lift things fast. You can even do touch on some minimal hypertrophy work if you wanted to improve tissue quality over the course of the season in low doses. It doesn't take much. I mean, 1 or 2 sets of 15 reps of something that's even somewhat close within 2 or 3 reps of failure would be hypertrophy work that would yield a massive amount of benefit without gassing an athlete out. You can touch on these qualities. It's kind of like the Tony Holler idea, like the feed the cats, right? It's just like these little doses of fun, these little doses of excellence, like you said. As long as it's intentional, and you touch on it, those qualities are probably going to still maintain, if not even improve, throughout the course of a season.
Agreed. All right. We're coming up on the hour and a half mark here. I'll end it on this question because I think this is a good one. It's a little bit open-ended. Coach Q, how do you define done with PT/rehab with your athletes?
Yeah. Fortunately for me, acting in more of a strength and conditioning role, that done is a very blurry line because we kind of are just rolling into continued training. And I think if you are doing rehab the same way you're doing training, which I think you should, that line does become kind of blurry. And at what point are you no longer just doing rehabilitation? You're doing training. That should be blurry from the very, very beginning of all of this. So When you say done, I think we should have some set standards or benchmarks, again, with that criteria that, once this athlete has reached this level of something, whether that's force, whether that's range of motion, that speed, that, movement quality, whatever things that are in our bucket of things that we decided is requisite to test. Those benchmarks should be the minimal thing that you're hitting, and maybe you have an agreement with a performance coach or a strength coach of when you as a rehabilitation provider are now passing on this athlete to their care to continue onwards for that remaining 10 to 20% of what needs to happen before they're actually full go returning. I think that's a reasonable way to do that. I think that as long as you have some testable things and some test measures in mind, that will get you 90% of the way there of when this person is done. And then how we maybe reverse engineer that is just compare athletes of their same position group and how they are getting the job done, what strength qualities they have if we're testing, the team. And that gives you a really easy measure of like, well, I know that, out of the 10 guys in your position, you're 60% of the way on average where they are. I'd like to see you get, at least average of your position group, if not exceed it. We also have GPS data, like how many yards are you covering per game or per practice, and how many of those yards are high speed? Well, I got to see you do that, in rehabilitation in some way or shape or form before I'm saying, yeah, you're good to return and we're done here. So I think just having some reverse engineered metrics on the front end will make that process a lot easier. But hopefully the person never really feels like they're all the way done, because rehab is training, and training it will continue onward forever. And the mindsets and the things that you had them attain during the rehabilitation process should carry on, inevitably.
Yeah, I think that's a great answer, and I think that's a good note to end this thing on. Well, listen, Q, from the time I met you, I knew you were something special. I'm so glad that you got into the sports performance world. I think it needs more practitioners like you, more DPTs who bring this training background, of these, a talented strength and conditioning coach, PT hybrid like yourself. I've learned a lot from you over the course of our time knowing each other. You've been a great friend. So it's been awesome just seeing you become more well known, as I always believed you should. And I'm sure it's nothing but big things on the horizons for you. So Q, where can people find you right now?
Yeah, easiest way to find me is probably on Instagram, Coach Q Physio, Coach_Q_Physio on Instagram is a really good place to find me. I usually respond pretty well to comments and DMs and things like that. Yeah, I'd say that's probably the best way, and we can always chat and reach out and help and a set of consults or whatever. I do all that remotely. I train people and write programs for people from all over the world with whatever they're dealing with, and so very comfortable in that space as well if people are looking to do that.
Yeah, well, I highly encourage you guys to go check him out. And Q, I mean, I hope maybe we'll see you back with Team USA at some capacity. I mean, just I can't say enough how gifted and freakish of an athlete you are yourself. I mean, everyone, if they've not seen you, they hear you speaking and just this very eloquent, educated, soft-spoken demeanor, but you're I mean, one of the most savage athletes I've ever met. So it'd be pretty cool to see you continuing to do some things yourself. But anyway, Q, I appreciate you taking the time to do this. This has been incredible. It's been super informative for me, and I'm sure my audience as well.
Awesome. Yeah, thank you so much for doing this and having me on, man. Appreciate all your kind words.
Yes, sir. And everybody, go Tar Heels. We will see you next time on the Hammer and Chisel Performance Podcast. Q, we'll talk to you soon.